Heidi Sandoz, which I'm sure many of you will know, a previous trustee and chair of the Society of Tissue Viability, and still a real massive supporter of what we do. Um, so Heidi is a tissue viability clinical nurse specialist, an independent tissue viability consultant, and also is our champion and the she leads and moderates, facilitates on our skincare champion program. And we talked quite a bit about equipment this morning. So Heidi's here to talk to you about the science behind pressure ulcer prevention equipment and how we select it. So I'm going to hand over to you, Heidi.
Thanks for that introduction. A lot to cover in this 30-minute session. So I'll start with my disclaimer. There are some pictures in this presentation of products. I'm not promoting any one product over another. I'm not suggesting that any one manufacturer's product is more effective than another. I'm just using those images for illustrative purposes. I do need to let you know that I do receive payment on occasion from a company called Educator for educational work and webinars that I do for them. So when I was given the title of this talk, at first I thought, oh, this is going to have to be about the science behind the equipment, what goes into it, how do they decide the type of foam, the alternating devices, what's the science behind that, the interface pressures. And I was thinking, how am I going to squeeze all that into half an hour? And then I looked at the last sentence, how do we select? And I thought, actually, a lot of you are here, it's an advanced day. A lot of you are here, will already have a lot of knowledge on equipment. And actually, what this session really needs to be about is to help us unpick that, what can be quite complex sometimes in how we decide to select our equipment. So what I'm going to try and endeavour to do in this 30-minute session is have a little consideration about what pressure ulcer prevention equipment is and try and explore the science of selecting the equipment rather than the science of the equipment. But actually, I might put a question out there to say to you, actually, is it an art rather than a science, a bit like compression bandaging? And then we'll have a little think about how we might consider how we select pressure ulcer prevention equipment to deliver optimal care for those people with complex health needs. And I'm going to attempt, and hopefully I don't make it more complex, I'm going to attempt to simplify the complexity of selecting that equipment. But I am going to start by saying this is not a black and white thing. When we're thinking about equipment, there are many, many, many factors that we need to put into play, and it really is not as simple as considering somebody's risk assessment score or the colour if you're using purpose T, or even the category of pressure ulcer that they've got. And very often in your areas, you might have policies and guidelines, you might have manufacturer posters that signpost you towards a particular product against a particular risk assessment score or a particular category of pressure ulcer. And it is not that simple. It is a lot more complex than that. It's a lot more like this. There's lots of shades of grey and white and lots of different shapes and sizes that we can make out of this picture here. So no one size fits all. And so what I want to try and do today is think about that science of the equipment and make that selection more of an art, really, if I can try and do that in 30 minutes. I hope I don't make it too complex. I hope that I do simplify it. And how we think about when we're designing care interventions for people with complex health needs, equipment selection isn't always that simple. So it can be quite a complex thing that we have to think about. And I'm going to be putting in this pot lots of different things that we need to think about. And sometimes it's going to involve trial and error. Sometimes you might suggest a piece of equipment with that person, they might agree to it, and it proves not to be the best thing for them. So we might have to reconsider and come up with something else. And whilst there is some science behind the design and manufacture of the pieces of pressure reducing equipment, I mean, we have, for instance, got a lovely mattress available to us that has come from US naval science and working with dolphins and making dolphins travel in boats, for instance. So there is some science behind it. I actually want to help you in a bit more of a pragmatic way understand how best you might select pieces of equipment to support pressure ulcers with your patients, residents, clients, whatever setting you are in. Little glossary here for some of the words that I might mention in this presentation, you might come across when you're talking to manufacturers of equipment. And I'm not going to go through each of these separately, but they're just here for you, and you can look back on this to look at those wordings. But I will point to the interface pressure picture that you can see there, that we call it a body map. This has been a device that's gone under somebody's body. That's actually me on a mattress. And I'm in a semi-recumbent position there. My legs are straight out in front of me and my back is supported by the backrest of the bed. And what that's showing you from the interface pressures is that I've got high pressures going through my bottom and my heels. So we all know this is the absolute worst position for people to be in when they're in a bed. But what this is also showing you is where there's low points of pressure or no points of pressure along my body interface. And if you're shown these kind of diagrams by companies, just ask them for a little bit more information. Was this picture that they're showing you somebody lying flat on their back, wearing their normal day clothes with no bed sheets on the bed? If so, does that equate into the situation that you find the people that you're caring for in? Usually not. Most of our people don't lie flat on their backs all day long. Might be true in an intensive care setting, but very rarely is that true elsewhere. So you need to think about how they've positioned that person on the bed and how that relates to the people in your care. Can they show you some positions with interface pressures where the body has been profiled in the bed? Because that will definitely show you a very different picture to the one that you're seeing there. As soon as we profile somebody in the bed, those red spots completely disappear. So it's just to get you to think about that if you've got companies coming to you with interface pressures. Thinking about what our guidelines tell us. So we have nice guidelines, and you will also probably in your areas of work have your own local guidelines and policies as well for pressure ulcer prevention. What NICE tell us is that we need to use a high specification foam mattress for adults who are admitted to secondary care. So any hospital setting, nowadays it would be extremely rare to find a bed that hasn't got a high spec foam mattress on it as a standard. If you're in the community setting and you've been assessed as being at high risk, then you should also be offered a high spec foam mattress at home. And then they also say use a high spec foam mattress for adults with a pressure ulcer. And if that's not sufficient, consider the use of a dynamic support mattress. Now, the reason why I'm showing this to you isn't so that you can all sit back and go, oh, I don't have to use a dynamic mattress all the time then. The reason why I'm pointing it out to you is because a lot of the time, because of the blame culture around pressure ulcers, people think that that's what they have to do straight away. And it's not always the best option for every person that you're going to care for. So I want to signpost you to what the national guidance says. But let's have a look at what the evidence says. So this top piece here is a Cochrane paper that has reviewed some of the evidence where there's been comparisons between different support surfaces. And they are saying that there's low certainty evidence that compared with foam mattresses, reactive air surfaces, so that will be your static air, and alternating or active air mattresses, so your dynamic mattresses, as well as reactive gel pads that might be used in theatres, for instance, may reduce pressure ulcer incidence. So that's come from some of the randomized controlled trials that have been out there, one of which I've put below. And also there was a big study that was done in England called the Pressure 2 trial it was published back in 2019. It's in the reference list. And in that study in hospital settings, and that included community hospitals, people randomized onto either an alternating air system, whichever system that hospital used, or onto a high spec pressure reducing foam system, whichever mattress that hospital used. And what they found was that there was actually very little difference between the two groups in who developed a pressure ulcer. However, it would take you longer to develop a pressure ulcer if you were on the alternating system. So I want you to think about the kind of people that these are. This is a group of people who have been admitted into hospital and are probably quite sick and poorly and very complex in their needs. What they also found was that it was actually more cost effective to use the alternating air mattresses in the hospital setting. But there was a core group of people that really benefited from those mattresses more than any other. And they were people who were very immobile and inactive, that had possibly some cognitive issues, so they couldn't always comply with recommendations of care. They were very, very undernourished, and they might have already had some skin marking or skin damage or pressure ulcers already in existence. So we haven't really got very strong evidence that points us to say that alternating mattresses do make a big difference. But we're definitely not going to stop using them because of that. We know that they help our patients, and it means we can leave them in positions for longer than we might have been able to if they were on a foam mattress. Quick little reminder about what we're talking about here. So we're talking about pressure damage. Pressure damage when that pressure is exerted on the tissue, so that the skeleton is pushing the tissue against the surface that we're on. Gravity is playing a part in that. You will start to get cell deformation. The cells will start to squash and change shape, and their cell wall might rupture because of that, and those cells will die. That will cause an inflammatory response in the body, which brings more fluid to that space, which increases the fluid in the spaces between the cells, which causes more edema, also causes more pressure. And then also you've got the additional ischemic effect from the pressure squashing the blood vessels as well. And all of that will lead to tissue death, leading to pressure damage. And we think certainly in studies that look at cells in the laboratory, that kind of cell deformation and cell death can happen in as little as an hour. So we do also need to think about the position that people are in and the posture that they're in, and how much gravity is forcing us to change that posture and scrunch down and slump down in our chairs and in our bed. And I'm sure when you're all sitting at home watching telly in the evening, you don't all sit upright in a lovely 90-degree position. Somehow you end up in weird and wonderful slumped positions. And if you're anything like me, you're constantly fidgeting out of those as well. So our ideal to beat gravity really is to be able to free float people either in midair or in water. Sadly, we don't have the option to do either of those things really. So we do have to think about how we can best combat that pressure, how we can limit the time that that pressure is being exerted on people, and what equipment we can use to support that. So we have a lot of selection considerations to think about. So let's start with the individual that we're looking at. Have they got any preferences? I've used my story of my spina bifida lady many times before. She will absolutely not go on an alternating pressure mattress in hospital because it immobilizes her. It prevents her from being active in bed, and it prevents her from independently getting in and out of bed into her wheelchair. So we do have to think that even though somebody's risk might look high, actually sometimes an alternating air mattress might increase their risk and lead them to develop a pressure ulcer. So they might have experiences in their past and preferences around certain pieces of equipment that they've come across. So have a conversation with them about that. Anything that we're designing here, where the person has capacity to be involved in that care, we need to be involving them in those decisions. What's their risk level like? And I'm going to, in my next slide, talk through Purpose T and how we can use that to guide equipment selection. Have they actually got a pressure ulcer? And if so, where is it? A category 4 pressure ulcer on the nose or an ear, for instance, isn't going to require an alternating air mattress, even though your guidelines might tell you that's what you need to use. So we do need to use some pragmatic sense around where the pressure ulcer is and what equipment might support that. If it's on a heel, then does an alternating air mattress really support that, or do we just need to find something that can offload that heel? What's their level of mobility and activity? And we'll come back to that with Purpose T. We also need to think about their weight and their size. Are they very long? Is the bed going to be long enough for them? They've got a sleeping partner. If we're talking about people at home or in care homes who are still with their sleeping partner, they might not want to have a separate bed with a different mattress. So can you get something that allows them to stay sleeping with that person? And are they a smoker? If they're a smoker, then you might want to have a conversation with them about not using air products or about not smoking when they're around those air products, because there have been instances in the country where that's caused a fatal death due to fire. So those are just some of the things to think about around the person's complexity, but there's going to be lots of other things that you might need to think about too. Contact equipment. So what type of equipment are you thinking of using? Is it foam? Is it air? Is it static? Is it plugged in? Lots of different things to think about there. Is it a mattress? Is it a cushion? Is it a chair? Is it a bed? So we need to consider all the different aspects of the equipment. In my experience, what I often find is that people will identify a risk and then they'll immediately start thinking mattress. And that's not really where we want to go first. And I'll come back to that. What's the functionality of that equipment? Is it a reactive piece of equipment where they'll sink into it and the mattress just reacts to their body being on there? Or is it an active piece of equipment like an alternating mattress where the cells go up and down in an alternating cycle? Always important as well when we're considering equipment, and this will probably be something that you're doing more at a strategic level and organizational level, is the quality of the material that covers the mattress. I was in a care home recently in Hertfordshire, and the mattress that this particular person was on had absolutely no stretch in the core, in the cover over this alternating air mattress, which completely detracts from the ability of the mattress to offload the pressure. So you're looking for a cover to the mattress that can give you 3, preferably 4-way stretch. It's breathable, a vapor permeable, and can consider that microclimate near the skin. Again, is your core material foam? Is it air? Is it a combination of both? Is it gel? There's a noodle mattress out there. If you haven't seen that one yet, Google it. There's lots of different equipment out there. We've got the immersion mattress from Dolphin, for instance. What can the company tell you about interface pressures and how relevant are those for you in making those decisions? Also, the age of the equipment. When was the last time any foam mattresses that you've got in your facility were tested for the fact that they're not bottoming out? How often do you unzip and have a look inside? How often has your electric equipment been serviced? So those are all things that are important to consider. Now, that mattress or that cushion sits on a chair or a bed. So the two really need to work together. And we're not going to just pop a mattress on a bed and then lie somebody on it. We need to think about how the function of the bed can also support offloading of pressure. So where you've got a profiling bed, then you can use that to also alter pressures as well. And always important, if you're sitting somebody up with the electric function, do the knee break first so that their legs are elevated when you start to sit their back up so they don't slide down the bed. What's their sitting or lying posture in the bed or chair? How well aligned are they? I haven't got more time to cover that really today, but that's a really important thing to think about. First thing to do when you walk into somebody's space is have a look at how wonky they are. Are they sitting up straight or are they tilted a bit? And might come back onto that. So what position do they need to be in? Are they somebody that can only lie in one position? And therefore, what kind of equipment might support them best with that? Remember, there's positional aids out there, and I'll show you a picture of some of those in a bit that might help better with posture than mattresses and cushions will. Again, thinking about that contact surface material and the core material. You might then also need to think about the environment that they're in. You know, what site are we talking about? Are we talking about a hospital setting or a care home setting where we've got 24-hour care around them? So we've got access to people that can reposition more frequently. Or are they in their own home where they've got carers coming in 3-4 times a day between the hours of 8 and 8 usually, and no care overnight? That might also influence your decision about what kind of equipment is needed. It might be that you have to think about equipment that can move them as well and reposition them. So what access to care have they got? What access to equipment? When a piece of equipment is ordered, how long is it going to take to get it? How often does it get serviced? And then also, what are they wearing? What clothing are they wearing when they're sitting or lying on this equipment? And what impact might that have? What bed sheets do they use? And have we also got layers of incontinence pads as well? And I'm sure there's other things in there that I haven't included that some of you will be thinking about. So it just shows you the number of different things that we have to consider when we're thinking about equipment. So let's have a look at the risk assessment and link that to equipment selections. We start here. This is Purpose T. Some of you might not be familiar with Purpose T. It's now the recommended tool from NHS England for England. We look at this top box here, which is talking about analysis of independent movement. You can see you've got some orange boxes, and the top left one there is they don't move and they don't move. So you're looking at the extent that they can move independently and the frequency of how often they move. So they're not moving at all and they can't move at all. The bottom yellow, for instance, might be people like you and I. We can move independently and we do major position changes all the time and we do it often. So those people won't be as much of a risk as those in the top left. So if you've got somebody who is doing major position changes, but maybe occasionally, and you put them on an alternating air mattress, that might make their major position changes harder to do. So you might have to think about them using a piece of equipment that doesn't alternate air, so they sink into it. You can't get a purchase, they can't move themselves. You might want to think about using a foam or a static product on top of that, which makes it easier for them to keep moving. But you might also need to encourage them to move more frequently rather than rushing for that alternating air mattress and getting it underneath them and plugging it in. So have a conversation with them about what they can do. Can they move more frequently? And if not, what pieces of equipment might suit them? We can then think about sensory perception and response. So how much can that person feel? When pressure's being exerted on the skin, will start to feel uncomfortable. It might start to feel painful. So when it's feeling painful, we might move because of that trigger. But if somebody can't feel that pain or they can't respond to feeling that pain, perhaps they've got dementia or a learning disability, then we might need to think for them in terms of moving because they might get the trigger of pain, but they're not responding to it. So they might be people that we need to think about putting higher spec pieces of equipment in, but also be thinking about how frequently they need to be moved. Now, I work in a community setting where people don't get moved very often at all because it's about access to carers. So very often in the community setting, and there's no research, just working with EPUAP on their repositioning section of their new guidelines for next year, and there's no research out there really on the community population. It's all hospital and care home settings. So we really don't know how long people need to be, how long people can go without being moved before they get pressure damage in that setting. And in my experience, it's always been a massive surprise to me that they don't get moved that often and they still don't get pressure damage. So it's quite interesting. But then they are all pretty much as a standard on alternating air mattresses. Just mindful of the time, I've got 7 minutes. So we can then think about people that have got poor perfusion problems. Now, very often this might be a central problem or it might be the foot. So if it's the foot only, somebody with peripheral vascular disease, can we target their foot for prevention? Do we just need to offload the foot and the heel? We don't need to be thinking about necessarily the mattress and the cushion. We might need to think about footwear. Might be that they've got a medical device and we just need to target prevention and protection of the skin under that, and we can use a variety of different things to support that. A mattress is definitely not going to help there. And it might be that we can have a look at this detailed skin assessment. We're thinking about pain oversights. Is there any vulnerability of skin oversights? Have they already got a pressure ulcer in any particular site? And we can target the equipment around that. So if I've got a pressure ulcer on my elbow because I sit in a chair and lean over to one side and lean on that elbow, and that's a category 4, what's the use of me having an alternating air mattress on my bed? We need to think about the history and the story behind that pressure ulcer forming. Then you've got things like nutrition and moisture and whether they've had a pressure ulcer in the past and diabetes. So when we're thinking about nutrition, moisture, diabetes, we're thinking about managing those conditions underneath. We want somebody to be well hydrated and well nourished. We want to keep their skin clean and dry, and we want their diabetes to be under control. So they've got previous history of pressure ulcers, then you may or may not need to consider what that risk is now. First thing that we want to do is think about how we can get people moving. So before we think equipment, think about how we can keep people moving, how we can keep their devices moving so that we can reduce that risk of pressure. And as I mentioned earlier, when you go in to see somebody for the first time, have a look at their posture. How wonky are they looking? How well aligned are their shoulders to their pelvis when they're sitting or lying? Just have a little think about that and think about what you might be able to do to support posture. Might be you need to get an occupational therapist or a physiotherapist involved. And we need to think about the 24-hour journey. Is this somebody that's in bed 24/7, 7 days a week, 52 weeks a year? Or is it somebody that is independent, working, needs to get out of bed and be in a chair to work? And what can we do about that? So, somebody, you might be caring for people who've got category 3 or 4 pressure ulcers over an ischial tuberosity over their sitting bone, but actually it's not appropriate for them to be in bed all the time and off that area. So we have to think about how we can best protect that area whilst they're sitting and living their best life as well. And if somebody's in bed, like the young girl you can see here, you can see that this bed is profiled. Her knees are elevated up, and that will offer better support through the sacrum than if she was just sitting with her legs straight out. And to add to this complexity, there is an absolute plethora of different pieces of equipment that we need to think about. We need to think about the bed, the chairs, the wheelchair. Do we need wheelchair services involved? Are there somebody that's developing contractures? What do we need to do to prevent them and protect their skin from that? I don't know if I can get my little laser on here. You can see here there are positioning aids that can help with posture and postural support. Devices like this that can help under medical devices, for instance, heel protectors, different variety of cushions. Often wheelchair services will be involved when they're very high spec cushions like this. Gel products, products for theatre, different kinds of mattresses, other heel protectors. This is an offloading cast made by usually by podiatrists. So many different pieces of equipment. And what I wanted to end on, I think I've got time, I've got 3 minutes, is thinking about that journey. Now, there's a lot of arrows on this diagram. And so first thing to think about is get them moving. Can you get them moving? What's the mattress they've already got at home? You know, there's some super good mattresses out there now that we can buy. And many of you've probably got one of your own. It might already have a memory foam in there. It might have a gel layer in there. It might be pocket sprung and very deep. So actually, if it's a good quality, fairly new mattress at home, that might be all that you need for them if they can move themselves. If not, you might need to think about some kind of static topper that can be foam or air that can go on top of that. Are they sharing that bed with somebody else, and how does that impact on their ability to do that? If that's not proving enough and they're not moving enough, then we might need to think about, do we need to add a profiling bed in to support their positioning? Then we might start stepping up to a high spec foam mattress with that bed. But we do need to remember that partnership with somebody else. If it's heels we're talking about, then just try and think about offloading the heels, and the same for elbows and other parts of the body that a mattress might not benefit. If this is proving not to be enough, then you might move on to a mattress that has got some air cells in it as well. So this can be hybrid mattress with foam and air, but the air can be plugged in or not. So it can be static, or you can plug it in and then those cells can alternate. And then finally, you might step up to a full replacement system that has got deep alternating air cells. And then beyond that, there is an immersion mattress as well, which may suit some people. So it's a lot to cover in 30 minutes. I'm putting this out to the companies. This is from Wolverine. I love watching Marvel films. And I think this is the ultimate bed and mattress that we need for patients. I don't know what it's made out of, but it's in Marvel world and it moves with the person. And I think this is the way to completely offload. So if there's any companies watching, can you please design that for us? And I just end with my list of references there for you all. And if there's any questions.
Right, it looked like he was on a bed of nails.
I know, but I don't think it is. I think it's some kind of fluid metal that stays in a solid form unless you move on. It looks cool.
Well, there you go. We'll put it out there to the companies. You never know. You never know. It could be the future.
Yeah,
Thank you so much. You did extremely well in 30 minutes. It was really informative. I think equipment is always, yeah, I mean, people are often, I suppose they are guided by formularies, aren't they, of what they have access to. And like yourself, you know, I was community based and was always in awe that more people didn't get pressure damage when they weren't really being moved, when, you know, but you know, the importance of equipment. Can I just be, I'm going to look through the questions, but just one I'm just interested in personally. We know that there is an increase now of these sort of turning systems.
yeah.
And the role that that plays in, and if you've got that in place, are there considerations around the surface, the equipment used on those sort of systems?
Yeah, I think so. I think they're great, and some of them go underneath the mattress, so they can be a good starting point because that means you might be able to just keep the foam mattress and you don't need to step up to air. Because if you've got the foam and they're repositioning, some of these devices can move people every 30 minutes. That might be adequate. If their skin is marking with that, then you might step them up to put an alternating mattress on top or a hybrid mattress on top of that device. Some of them are air mattresses that have the tilting option within them, and they'll either the mattress will tilt or it will drop lateral cells down, and the patient will tip into that space. So it really depends on the kind of equipment you've got. I think also if you look at some of the positioning aids, like the PosiPearl that I showed a picture of, you can use those to support posture, and that in itself can redistribute pressure as well.
Someone's asking about if you're using an alternating air mattress, would you need to use heel boots as well, or is the mattress sufficient?
So I would say, do you need the alternating air mattress if the problem is the heel? I think I'd look at it that way around first because it's much easier to offload heels on beds than it is bottoms. So if the heel is the problem, you might be using a device to offload that heel. It might be a blow up boot or it might be a pillow, some as simple as a pillow. Or and you might also be profiling the bed as well because using that knee break profile in a bed can offload the heels too. Um, an alternating mattress, some of them will say to you they've got smaller cells over the heel, or they might have a foam section or a sloping section. So you've got to take all those things into consideration. Just being on an alternating air mattress alone is probably not going to be enough to support heel prevention and protection. So you might need to add something in as well. That very much depends on the mattress.
There's a comment here about sort of blame culture and the lack of understanding, and often people jump to things like air mattresses as like a default without really considering that wider picture and positioning, etc. And I know some organisations have got sort of just, their default piece of equipment. There's a lot now around this hybrid idea of some alternating system and some maybe high spec foam. Have you got anything to maybe comment around that sort of
No, I
approach?
think I think they're quite a useful product. We don't really have any evidence around them. They weren't included in the Pressure 2 study, really. So we don't really know if they offer a better benefit in terms of effectiveness against prevention. But they are a useful product and they're probably more commonly used in a lot of places as first line after a foam. Very nice if you know you've got somebody that's going to progress into a more immobile state. So this might be somebody who's end of life, for instance, where you can start them off on that mattress. So it's foam and air, but it's not plugged in. And then as their condition slowly deteriorates and they become less mobile, you might be able to plug that mattress in so that they've then got the alternating function as well. And you haven't had to think about getting one mattress out from underneath them and putting them on a higher spec one. So I think in that scenario, they're really useful as well.
There's a comment here around what you raised earlier around smokers.
Yeah,
In the community, they struggle with providing appropriate equipment for people who do smoke.
yeah.
I mean, there are some real good quality sort of static systems, aren't there? And it's about positioning and things as well, isn't it? I would
Yeah,
imagine.
yeah, definitely. I think it's about having a conversation with that person so they're aware of the risk. If they're living in a block of flats, I wouldn't, and they're insistent that they're going to keep smoking on their air mattress. I wouldn't give them an air mattress of any kind or cushion because there's multiple people at risk if that leads to a fire. Um, you might stick with considering foam in that situation, but have a conversation with them. If they're in the middle of nowhere in a farm and it's their own house that's going to go up in smoke and they're quite happy to take that risk, maybe your organisation will take that risk with them. But I think there's a complex conversation to be had around that.
There's comments around obviously things like rail heights of rails when you use various bits of equipment. That I suppose it's just around risk assessment, isn't it?
It is, yeah. And anybody that's having side rails added on and the tilting mattresses, you've probably got some kind of risk assessment in your organisation that you use to choose both of those things. And certainly when they're used together, I mean, these tilting devices don't tilt people a lot. They're not going to flip them out of bed, but they can feel to them that they might be moving up. I think the Toto company once said to me when they tested the tilt, they'll say it goes 45, but actually it was more like 15 to 30 degrees that it was tilting.
Yeah, so, that's what I've heard is sometimes people feel, when they get used to it, it feels quite dramatic, but it is actually quite subtle, isn't it?
Yeah, yeah.
The movement, but it's, there's certainly a place for that sort of equipment. Let me just check and see if there's any other
Think somebody
questions
mentioned
here.
spinal
I
cord,
think,
didn't they?
so what,
Um,
sorry?
Somebody mentioned spinal cord injuries. So
Yes, I
you're
think it was, yeah, it was your reference to, I think, in Purpose T around the sensory perception and response.
mm.
Really important to acknowledge that in spinal cord injuries. But is there any specific advice when people have spinal injuries around equipment?
So I think early on, in that initial injury stage, you're unlikely to use an alternating air mattress for your spinal cord injured people because that might add a risk in to them. So they're more likely to be nursed on a high spec foam or some kind of mattress that isn't going to be alternating and moving them. But as they develop through their life with their injury, then it becomes more of a stable thing, and they might use those devices later on in their journey if needed.
I think really also, I think you mentioned at the beginning around, people automatically think mattress. And from my experience, again, we have people who'd have some sort of high spec mattress on the bed, but they were sitting out for most of the day and all they had was a basic foam cushion. And I think that needs to be considered, isn't it, where the risk is. And often cushions weren't adequate. I don't know if you've had that experience
Oh
and
yeah, absolutely. We do need to think about the 24-hour journey of that person. They might only spend 6 or 8 hours in bed and the most more time in a chair. Also, if we're popping a cushion on top of a chair, whether that's their sofa, their armchair, or a riser recliner chair or their wheelchair, how does that cushion impact on the height of that chair and their ability to sit on it? The most ideal is that any cushion that we use is integral to the seated surface that they're on, where you can get that. So you don't want a cushion on a chair that is then going to raise them up so that they can't push their arms down onto the chair as well to stand up, so that their legs aren't touching the floor, which will mean they might slide themselves forward, put their feet on the floor, but then they're sitting on their sacrum in the chair. And that might also put more pressure on their spine as well. I've been seeing more people with pressure ulcers down the vertebra. I think because as the population is getting older, we're getting more kyphosis in the
yeah.
spines. And so often square back seating doesn't suit that, and you can get pressure damage and same on the bed. So some of the riser recliner chairs with the waterfall back, so you can take the stuffing out and it allows the spine to sort of immerse into that space, can be really useful in those situations.
Brilliant. I don't think there are any other questions. No, no. So I'm going to draw that to a close then. So thank you so much, Heidi. That was really
Thank you.
informative. And thanks again for supporting our study day.